All right, so with this, I'm going to go over the GI medication packets. So the first thing I want to do is talk about our peptic ulcer disease, what it is, the signs and symptoms, and the treatment. So I went in depth on this a little more in the PowerPoint, but big things is just the signs of a gastric ulcer. Is going to be pain with eating. Eating is going to exacerbate the pain, so these patients aren't going to want to eat, so they may be malnourished. And they may have the hematemesis, which, if you remember, is that bloody vomit. With the duodenal ulcer, food is going to act like a buffer, so food is going to make them feel better. So their pain is going to be a couple of hours after eating. When that food is digesting and leaving their system, that's when their pain's going to happen. Because eating helps them feel better, these people are going to be well nourished. And they can have the melena, which is that dark, tarry stool. Essentially, it's digested blood in the stool, so it's a sign of a GI bleed. Same with the hematemesis. That's that coffee ground or bloody vomit, and that can be signs of a GI bleed as well. So our treatment of peptic ulcer disease is typically a polypharmaceutical treatment, meaning multiple medications. A lot of times PUD is caused by a bacteria called H. pylori. And that, since it's a bacteria, antibiotics are a lot of times prescribed. So I'm not going to go in depth into that because we already talked about antibiotics on week 2. We can also have H2 blockers, which is, we're going to talk about PPIs, antacids, and mucosal protectant. Okay. We have our H2 blockers, which are going to end in tidine, tidine, famotidine, cimetidine, ranitidine. And it's going to be used to suppress or decrease gastric acid production. So it's going to stop our body from making the gastric acid. Some complications that come along with this is our androgen effects. Remember, androgen is our male hormone, like our testosterone. So if we are blocking that, or it is anti that, we are going to block some of that male hormone. So that's going to come with the gynecomastia, decreased libido, and impotence. And then we are going to also have a decrease in the central nervous system, meaning we're going to have lethargy, restlessness. It could even go so far as confusion and hallucinations. The higher risk for this is in an older person, but even then, you can get this at any age. They're just more likely to have that in older individuals. Some nursing considerations is We do not want to give it with antacids. Remember, antacids pretty much interact with everything, so we want to give those by themselves. And we'll talk about a little more when we get there. The biggest thing for client education is to report signs and symptoms of a GI bleed, which we talked about earlier, that coffee ground emesis or that dark tarry stools. We also want to monitor them for signs and symptoms of bleeding, because that is going to be our number one side effect of a peptic ulcer, is a GI bleed. Monitor for signs and symptoms of bleeding. So that's going to be our low blood pressure, our high pulse. We can have them lose consciousness because they are losing blood to the brain and we don't know it, especially if it's an internal bleed. And then that petechiae or easy bruising is also a red flag for us. Other things is we want to teach the client to not ingest things that are going to cause the GI irritation. This is things like alcohol, caffeine, and smoking, and NSAIDs. So remember, if we don't want to take NSAIDs, our over-the-counter pain medication of choice is going to be the acetaminophen. Okay. All right, so now we got our PPIs, and those are going to end in Prazole. These are just a few of them, but if you see Prazole, you should think PPI. So once again, the use of this medication is going to be to stop acid production, typically used for 4 to 8 weeks. That's a normal course of this. Sometimes it can be used for long term, but we worry about some complications. So our short term treatments can just be a little bit of nausea, vomiting, and headache, which can usually be treated with medication. Our long-term side effects, so this is why we have to have a thing where the risk of the long-term effects is outweighed by the benefit of using the drug long-term. So some long-term problems are going to be that pneumonia, osteoporosis, rebound, acid production, and low magnesium. Okay. Again, our client teaching. Oh, and it can also in long term cause that C. diff. So we want to report any kind of diarrhea, things like that, or bloody stools. Biggest things for our nursing is we do not want to break, crush, or chew. So these are pretty much treated like a extended release medication. And do not open the capsule and sprinkle on food either. Okay. Typically, they're going to take this medication once a day. So we take it once a day, and we need to report any signs and symptoms of bleeding, which we just talked about. And the other, we'd already talked about report any kind of diarrhea because we're worried about C. diff. Okay. Our next medication is going to be our mucosal protectants, which is our sulcrafate. So for this, it's really just kind of act like a Band-Aid. So it's going to give a protective barrier to the ulcers in order to stop them, to cover them up and let them heal, just like you would do with a Band-Aid. Because of this, there is no systemic side effects. Just because it's essentially plugging up pieces in your stomach, you can get constipation. And with constipation, of course, we're just going to increase fiber, fluid, and exercise if appropriate. Okay. This is typically our nursing considerations. This is typically going to be given 4 times a day. So with meals, which is AC, and HS, which is bedtime. We can break these. Okay. And really, there's nothing more to teach the client aside from do not mix with antacids, which we've already talked about. You can't take antacids with hardly anything. Okay. So now we're on to our antacids. So antacids can be made from aluminum, magnesium, calcium, or sodium bicarbonate. So the use of these, if you think about it, you typically use antacids when you actively have heartburn or GERD. So this is going to neutralize the acid that's already there. So this is going to try to help bring down some of that acidity. So we talked about how they're made out of different types of materials. So our calcium and our aluminum are going to cause constipation. Whereas our magnesium based, like our magnesium hydroxide, is going to cause diarrhea. Okay. Of course, our big things, they can also, because we're adding these different types of, we're eating calcium carbonate, that's going to increase our calcium. Eating mag is going to increase our mag. Things like that. So with our aluminum based, we are worried about low phosphate. And we are worried about high calcium. With our calcium. And then, of course, magnesium. We're worried about our high magnesium. Okay. Biggest things is we have a risk of alkalosis. Because we're neutralizing that acid, we can become too basic. So we just need to be careful about that. And we want to not use these in clients who have GI obstruction or kidney issues. And then with our client teaching, we want to do not take antacids with other medications. Remember, we want to be at least 30 minutes apart from other meds, if not longer. Okay. So then with our misoprostol, we got the misopregnant, so I don't take. There are several uses for this. This can be used for somebody who has to be on long-term NSAIDs to help protect them. This can be used for, so this would prevent the gastric ulcers. Because of what it does to pregnant people, it can be used to induce labor. Cause or use it for cervical ripening, which we'll talk more about in OB. And then, of course, to terminate a pregnancy. But unless your goal is to induce labor or terminate a pregnancy, no pregs, okay? The biggest thing we're going to get with this is diarrhea, and then, of course, dysmenorrhea. The reason we're going to get dysmenorrhea is because of what it's doing to the cervix and the uterus and things along those lines. So, of course, we're going to tell them not to get pregnant. And use contraceptive measures while on the medication. And our nursing administration is typically just like our Carefate. We're going to give it ACHS with meals and at bedtime. Okay. So now we're going to move on to our antiemetics. Antiemetics are used for nausea and vomiting. So that's what all of them are going to be used for essentially. So the first medications we have are our serotonin antagonist. This is going to be our ondansetron. These ones end in cetron. Of course, if they're serotonin antagonists, they're going to block serotonin in the brain, which is going to work in our vomit center in our brain and help reduce the nausea. It's typically used for post-op or chemo-induced nausea and vomiting. We have a couple of complications that are pretty unique to this drug, and that is headache, diarrhea, and dizziness. And then we can have a prolonged QT interval, which means that we need to monitor the heart and get a baseline EKG before starting. Okay. Our next one that we're going to talk about is our dopamine antagonist, and this is going to be our prochlorperazine or Methazine. Composate is the generic or the brand name for this one. If you've ever heard of that, it's a lot of times used for like a migraine headache. With the migraine headaches, it can also be used for post-op and chemo, nausea, and vomiting. With that being said, the reason we use it for migraines isn't to get rid of the headache itself, but it's to combat the nausea and vomiting that come along with migraines. With these, our complications include our extrapyramidal symptoms, or EPSs. So these are our movement disorders. We'll typically use diphenhydramine or benzotropine to treat the EPSs, but they need to monitor and report any kind of neck or face spasms and notify the provider and stop the medication. It can cause hypotension, so a low blood pressure, as well as sedation. So we just need to be mindful of that when we're giving it. It is also an anti-chlorogenic, which is that can't pee, can't see, can't shit, can't spit. So it dries everything up. Okay. Our next one is our cannabinoids, and this is cannabis derived. Our drug is dronabinol. The use for this is it can help with nausea and vomiting, but also what it can do is increase appetite in those with wasting syndrome, which comes with AIDS and ADHD. So those who have anorexia with AIDS can use this to help them eat again. With this being a derived from cannabis, we do worry about dissociation. And dysphoria, meaning like hallucinations. So it is contraindicated in those with mental health disorders. And it can also cause a low blood pressure and high heart rate. Okay. And then our next class is essentially our anti-chlorogenics and our antihistamines. These drugs are going to be our scopolamine, hydroxyzine, and our dimenhydrinate. And is going to typically be used for motion sickness. So as it says kind of in the class name that they're anti-chlorogenics, they can cause sedation and the anti-chlorogenic effect, which is the can't see, can't pee, can't shit, can't spit. If I drill anything into your head this semester, I hope it is that. Okay, so now we're going to talk about the other way. So now we're going to talk about our laxatives. We have 4 different types that we talk about. We have our bulk forming, which is our psyllium. This is going to be the closest thing to natural occurring fiber. Okay, and the goal of this is to, as it says, increase bulk and help provide a bowel movement. So this is the same thing. This is just like increasing your dietary fiber. The biggest thing with these that we need to tell our patients is that we want them to take it with an entire glass of water. Take with fluids. And the reason for this is that bulk can form a obstruction. All right. So then our next one is going to be a surfactant laxative. This is going to be our Docusate. So the goal of this with the surfactant, it's going to lower the surface tension of the stool. Allow water to get in so it can pass more easily. The biggest thing with this is it can cause GI irritation, so we don't want to crush or chew. It can also cause kind of issues with our electrolytes. So we want to monitor those as well. The next one we have is our stimulant laxative. This is going to be our Senna and Bisacodyl. The goal of this medication is to increase peristalsis. And if we remember from fundamentals and our abdominal assessment, those are those gurgly sounds that are helping to push everything through the GI system. So this is going to increase that to help make going to the bathroom more easier. Of course, with this one, we can get electrolyte issues. And also with these can come in suppository form. So they can cause rectal burning. So biggest thing is we don't want to use regularly. Pretty much any laxative you don't want to use regularly. The only one that's safe would be the bulk forming. And then we have our osmotic laxatives. This can be either our magnesium, so like our milk of magnesium, or lactulose. The biggest thing with lactulose is it's used to pull ammonia off the brain. So for this one, it's going to increase peristalsis, but it can also help rid the body of any kind of parasite or anything like that, along with removing ammonia. So we would want to monitor the ammonia levels. These ones, because they're pulling so much water into the intestine, we can get dehydration. So we would need to make sure our client stays hydrated. Okay. So then we have some other drugs that kind of go with these. I did not put our anti-diarrheals on here, so I'll add that over here. The biggest thing with these is they're anti-chlorogenic. So can't see, can't be, can't shit, can't spit, because we're trying to stop that diarrhea. And our drug of choice is going to be DIPHEN OXYLATE and atropine. Okay, those are your biggest things to know about antidiarrheals. And then we have our prokinetic agents. This is macrolide. This is metchlorpromide. With the metchlorpromide, this is also a dopamine agonist, so it can be used for nausea and vomiting. So it does that same thing by blocking the dopamine in the central nervous system. But this also, it's used as a prokinetic, pro meaning increase or more, kinetic meaning movement. It can be used to increase peristalsis. In somebody who may have low peristalsis, things like that. Just like with our dopamine antagonists that we talked about earlier, we can get those EPSs. So same things apply: sedation, diarrhea. Okay. Then we have our medication for irritable bowel syndrome with diarrhea, or IBS-D. The medication for this one is Olacetron. So of course this is used for IBS-D. Only approved in female clients because it's the only one it's been seen to work in. And this is kind of a last case drug simply because it can cause so many issues that you can only get this medication by a special risk management provider. And you have to sign a consent for it. So this one requires special consent. Because some of the, and you can see this in your book, some of the, of course it can cause constipation because we're trying to stop the diarrhea, but it can also cause rectal bleeding, bloody diarrhea, abdominal pain. It can be fatal with GI toxicity. So, and then we don't want to give it to somebody who has, chronic constipation, bowel obstructions, Crohn's disease, ulcerative colitis, impaired intestinal circulation, diverticulitis, GI perforation, adhesions, or thrombophlebitis. So there's a lot of risks that come with this, which is why it needs special consent. Okay. And then we have our medication for IBS-C, which is irritable bowel syndrome with constipation. And this is our BIPROSTONE. And the uses are going to be, of course, once again, only female patients with IBS-C. Because it's the only one that's been proven to treat it in. It can cause diarrhea, once again, because we're trying to break up that constipation. and also nausea. So we can take it with food to help with the nausea. And then hopefully the client gets relief of constipation. And that is it for your GI packet. So I hope you enjoyed this second lecture. And once again, make sure you put any additional questions you may have in that Ask Your Instructor forum so that I can address them in class.